Good morning, everyone. It's good to be here with you today. My name is Tanae Franklin, and I am with Health Leads USA, where I focus on health equity and community engagement efforts. And I'm excited to continue our learning today with our panelists that we have here with us. We have Dr. Lindsay Mayberry from Vanderbilt University School of Medicine, Dr. Lisa Fitzpatrick, founder and CEO of Grapevine Health, and Dr. Darcel Reyes from the Rutgers School of Nursing. Now, in order to save time, I'm going to ask if you would like to see their bios that you click on the details portion in the agenda and you can read all about their background. But I'd like to jump right in so we can have most of our time for our conversation today. And I'm going to start with Dr. Lindsay Mayberry from Vanderbilt University School of Nursing. Dr. Mayberry, you're on. And I think you're on mute.
Thank you. Thanks so much for having me today. I'm excited to talk to you about how we can bridge the gap between personal and organizational health literacy to improve patient outcomes. I'm coming to you in my capacity today as the director for the Effective Health Communication Core at Vanderbilt. We do provide consultative services to help you with some of this work if you should need. So to start, I think you guys know what health literacy is, but I think it's important for us to understand a little bit of the history of the term and what the evolution might mean. So initially, we define health literacy as the degree to which an individual has the capacity to communicate, process, and understand basic health information. But that definition is outdated, and now we define personal health literacy and organizational health literacy. And so personal health literacy is the ability to find, understand, and use health information, whereas organizational health literacy is the degree to which organizations equitably enable. And so I think this is a really important change, that instead of thinking about the capacity of an individual as sort of a characteristic, we think about the interaction between the individual and the context. And this definition acknowledges that organizations have a responsibility to address health literacy as well. So how does health literacy lead to early mortality? This is why it's important. And we know that there's all these different pathways or things along the pathway from health literacy to poor outcomes. And so here are some of the ones that we know are big players in this relationship. People with lower health literacy often delay seeking healthcare because they don't recognize early signs, or they have fear or uncertainty about how to access care. Also, limited education, which is associated with lower health literacy, leads to limited socioeconomic opportunities and structural inequalities, built environments that make healthy living more challenging, and accumulating stressors that worsen health, but they also make health and health literacy less of a pressing priority when people are balancing more basic needs. There's also a lack of understanding of recommendations, but also just a lack of confidence. And, one of the things I think is really critical in Dr. O'Leary's talk is the recognition that this happens to everyone. But often, if you have higher health literacy or you have an experience in the past of understanding, you will say, wait a second, I don't understand. We need to address this. Whereas somebody who maybe often doesn't understand won't feel efficacious or empowered to ask those questions and get those clarifications. Barriers to applying medical recommendations, including difficulty obtaining medications or needed supplies. And finally, just a lower sense of control over one's health outcomes or where to go for trustworthy information, which leads to avoidance. We all avoid things that make us uncomfortable and uncertain. And so we looked at this in our science. We looked at, we know that lower health literacy leads to 1-year mortality after hospitalization for heart disease. So we wanted to see, if we look at all these things that are on that causal pathway, can we explain that relationship? So we looked at health competence, that sense of control, health behavior, social support, and then measures of sort of complexity of the medical condition. And what we found was that the effect of health literacy through these mediators, these mechanisms, was really sizable. A person with lower health literacy would be on average 13% more likely to die within 1 year of a hospitalization for heart disease than a person with very high health literacy. And this is independent of age, gender, race, ethnicity, and socioeconomic status. What's really critical to understand is that after we adjust for these mechanisms, there's no longer a relationship between health literacy and early mortality. And that means we have a pretty good sense of how health literacy leads to poor outcomes and where to intervene in the pathway to prevent that from happening. So we know where personal health literacy comes from: education, reading comprehension, numeracy skills, but also familiarity with and exposure to the healthcare system, and then the ability to seek out and identify trustworthy information, which we have all seen really play out in our current environment. But let's talk about what makes an organization health literate. Implementing strategies that make it easier to navigate the healthcare system, making accurate information easy to understand and readily available, and implementing strategies that make it easier to engage in health. So, what do we do with this information? We know that people with limited health literacy have this gap to overcome to get the healthcare they need and avoid poor outcomes, and we want to help them. Often the first way we think about improving health literacy is let's identify folks with limited health literacy and work with them to improve their health literacy skills. And so that's like teaching this person here in the picture how to build a bridge to the other side. It's a lot of work and it may be really effective, but it may be only effective for those who have the time, ability, and interest to sign up for our bridge building lessons. So organizational health literacy emphasizes the importance of the healthcare system building the bridge from their end, which is critical, but not all healthcare organizations are committed to this. And people have to interact with healthcare organizations all along the continuum from low organizational health literacy to high. So it's kind of like expecting this person to get halfway over the chasm and just hope the second half of the bridge has been built. But what's really critical, and what I'm glad Dr. O'Leary pointed out, is that community organizations can become health literate too. And this has to do with implementing those strategies. So I'm going to talk to you about some strategies that are evidence-based that have been proven to be effective. The first one is patient navigators. These are people inside your organization who are familiar with the healthcare system, and maybe they are retired nurses or they work for a health insurance company, and they can help organization members make decisions about health insurance, attend visits, ask appropriate questions in their appointments. Folks with technology skills can help your members to attend telehealth visits, to sign up for and use patient portals. And then also we have this idea of sending relevant information. Instead of trying to teach people how to seek out and find relevant information, let's send it directly to them from a trustworthy source. And so if your members trust your organization, you can use clear messaging via text message, via mailing, via automated phone calls to send the timely information directly to your members that you want them to have. And we've shown in our work that text messaging can change health behavior and improve outcomes when it comes from a trusted source. And then health check-ins. This provides a touch point between your member and someone within your organization that's trained to reach out and see how are they doing? Do they have any new symptoms? Have they gotten their medications? This can be very effective if it's time to the year after people are hospitalized. It helps them identify those things early on so they don't end up in the emergency room or back in the hospital when problems have gotten so complex. And then what else can your organization provide? These are some evidence-based things that have been shown to help bridge this gap that community organizations can do, but there are other things that your members may need. And so this is sort of an exaggeration, but I think it's often the first thing we think of to reach out to the people we've identified as having lower health literacy. But as Dr. O'Leary pointed out, that's not the right approach. The right approach is to meet the need of a wide range of audiences and use health literacy strategies in all communications. So here are my best practices. I think here's how you do this. Screen for low health literacy. The measure I recommend is the brief health literacy screen. It's 3 items. Develop programs to be appropriate for persons with lower health literacy. Engage persons with lower health literacy in program development and advertising, but make the programs useful for and available to everyone. Use the screening information to make sure that your programs are advertised to, accessible, and being used by some folks with lower health literacy. But not only people with lower health literacy can benefit, also people who have higher healthcare need can benefit from these programs. So not focusing only on those patients who screened as positive for lower health literacy. And here are some sources to learn more. The Vanderbilt Center for Effective Health Communication, we're here to help you. And I think that's my time. So thank you for your attention.
Thank you, Dr. Mayberry. Everyone, we're going to save our questions to the end of this session for a better discussion. And I'm going to turn it over to Dr. Litsa Fitzpatrick. And Dr. Fitzpatrick, you might be on mute.
How many times have I done that? Good morning, everybody. It's nice to be here with you, and I appreciate the invitation to come and talk to you a little bit about some of the work I'm doing focused on health literacy. I don't have slides. I just wanted to chat with you a few minutes because I think some of the interactions we have in the community are very instructive about how health literacy emerges or how it presents. And sometimes the presentation of low health literacy can be very subtle. But before I talk a bit about what we're doing with Grapevine Health and some of those insights, I wanted to respond to something Katina O'Leary mentioned, and it was how to approach patients who might have low health literacy. My experience in my clinic is that people are often afraid when they come in and they are confused. And our body language is really important. So she mentioned some of this in her discussion. And I just wanted to remind, if there are any clinicians here, people pick up on our subtle clues, and not just the hand on the door, but if we never sit down to talk to them, it gives the impression we're in a rush. And I've had a person tell me, well, I didn't realize I could ask my doctor follow-up questions. He always seems so busy. So I want to thank her for pointing that out, and just wanted to add my 2 cents about that. So what about Grapevine Health? We are on the ground conducting outreach with communities of color. I'm in Washington, D.C., and our focus is largely on the Medicaid population. We've done some work with some of our Medicaid insurance companies, and some of the conversations we have with Medicaid beneficiaries are very instructive. So I wanted to give you a couple of examples for you to think about. The first one is a young lady we spoke to because she'd used the emergency room 13 times in a 6-month period. So my conversation with her was, the purpose of my conversation was to understand what her challenges were and why she preferred the emergency room. And her answer, well, she had two responses. One was, well, the emergency room makes me feel better. I have a doctor, but my doctor doesn't know what's wrong with me. And the second was, I get better information when I go to the emergency room. And so when I asked her what that meant, she said, well, all of my questions can get answered in the emergency room. She said, but one day when I left, I got home and I looked at the paperwork they gave me. And it had this word on it I had never seen before. The word was gastroparesis, and she actually pronounced it correctly. And she said, well, when I saw this word, it terrified me because I thought it meant my stomach didn't work. Because I know I went for stomach pain, and I know paresis means something doesn't work. So does my stomach not work? And I thought it was just a really important example of how we give information in the healthcare setting, whether it's written or verbal. And if we don't take the time to follow up, we create unnecessary stress for patients. And the second one was actually a very humbling conversation for me. It was a gentleman in his 70s. And similarly, I was speaking to him because his healthcare utilization was exclusively in the emergency department, even though he had insurance, and his insurance company had assigned him a doctor. He'd never met the doctor. We had about an hour-long conversation, but it wasn't until the end of the conversation I understood what was going on with him. I asked if I could send him a text message to follow up because in our work we focus heavily on text. I'm very interested in talking more to Lindsay Mayberry about the work they're doing with texting. But he said, no, just call me. And I said, well, it's easy. If you have a question, you can text us anytime. He said, well, I prefer just to talk on the phone. And that's when it clicked for me that he couldn't read, or he had very low reading ability. And we talked about it, and he was open about his challenges with reading. But he was over 70 years old, and no one had picked up on the fact that he couldn't read. So it was too difficult for him to navigate healthcare. And imagine what that's like. We give people a lot of paperwork to sign. We use big words. And if we don't pick up on the subtle clues, again, we're causing undue harm and undue stress on the patients. And then the final one is my neighbor, who gives me a lot of insight about the impact of low health literacy, not just on the cost of care, but health outcomes. And he's a gentleman who's been told he has a heart condition, but he doesn't believe the doctors. And the reason he doesn't believe them is because he doesn't understand what they're saying. And he says, they're telling me all of these things are wrong with my body, but look at me, I feel fine. So the information he was being given didn't comport with his reality or how he felt, which created distrust. And that's the final thing I would like to touch upon. The distrust we're seeing in the health community with the healthcare system and the health community, especially right now, it seems to be at an all-time high, but we've known this for a long time. But I think the distrust is exacerbated by low health literacy, so that if we don't take the time needed to connect with people and understand their challenges and ensure they understand their health conditions, it continues to foster distrust, which the downside effect of that is they are continuing to use the highest and most costly forms of healthcare, emergency rooms, avoidable hospitalizations. My neighbor also won't take the medications he's been given by his healthcare provider because he doesn't understand what's happening with the medication and why he needs to take it. So I'm sharing these stories because I want us to all be vigilant for the subtle clues to look for low health literacy and how it's linked to poor engagement or poor health outcomes. And you might be asking, well, what else can I do? The common thread for all of these people, I think, is the need for support. And when I was asked to talk here today, it was mentioned there are quite a few folks from the faith community in this group. And I think there's a vital role the faith community can play to support people, not just to provide support with navigation to health services, but I also think just bringing health information, understandable health information, or making it more accessible for people so they feel comfortable engaging in healthcare. We're talking a lot now about the need to diversify the pipeline. I mean, it's no secret that a lot of Medicaid patients are Black and Brown people. We also know there are data that show health outcomes are often better when there's a Black or Brown healthcare provider taking care of these patients. But there aren't enough of us to go around. So how can we facilitate the engagement and the connection? I think the faith community can be a bridge to help build trust with the healthcare community. And you can do it by helping us translate or speak in culturally appropriate language so that people can understand what we're talking about. I think that's the bottom line. I spoke to a group of gentlemen at a shelter, and he said, well, you know, I don't trust doctors because I don't understand what you all are saying. And if I don't understand you, I don't trust you. So I think there are a lot of ways that we can support people with low health literacy. First, just by noticing, and second, by providing the support, even if they don't ask for it. Like the woman who said, well, I didn't know I could ask follow up questions. That's a form of support you can offer just by helping to educate people about or giving them permission to ask questions and seek the information they need to be healthier. So I'll stop there and look forward to any questions.
Thank you, Dr. Fitzpatrick. Again, everyone, we're going to save questions to the end. And I'd like to move on to Dr. Darcel Reyes, please, from Rutgers School of Nursing.
Hi, good morning, everyone. David pulls it up for me, and he's going to be clicking through because while I know a lot about health literacy, I am technologically impaired, and that is not my strength. So thank you, David. Could you click to the next slide, please? Can you go to the next slide? Okay, so what we've all been saying here is that we make an assumption that communication has occurred, but we really don't know if it has. Next slide. And I'm going to show you some examples of that with some cartoons. So in this cartoon, the nurse asks the patient to fill out the form, and the patient says, I can't read or write. And the nurse says, poor dear, suffering from poor vision and a sore hand. And this just illustrates that so many times we don't recognize as clinicians that our patients don't have low literacy. We attribute their inability to understand us to other reasons. And people with low literacy very rarely say that they have low literacy, but are highly intelligent people because they're navigating this world without all the signs and signals that we as readers and educated people use to get along in the world. Next slide. And yeah, just the next one. So here, do patients understand what we are saying? So in this cartoon, the doctor calls the patient to give them results. And he tells the patient that all the results are negative, and the patient responds, oh God, how much time do I have left? And the doctor said, no, that's a positive thing. And the patient says, a negative is a positive? And the doc says, yes. So he says, so the patient asks, what's a positive thing? And the doctor says, positive thing is a negative thing. And the patient asks, are you sure? And the doctor says, I'm positive. And the patient responds, oh God, how much time do you have left? So our ideas, our language doesn't always translate to regular people. Next slide, please. And again, we may not always understand what our patients are talking about. In this slide, nurse or doctor is at the bedside and asks, what brings you to the hospital? And the patient said, I had a bad case of shingles. And the healthcare provider says, well, you can get a vaccine for that. And the patient responds, no, I'm a roofer. So words have different meanings for people, and we have to be aware of that as we communicate. Next slide, please. So how much information can people retain? The research says you can just click a couple that it'll show up. The research says that people remember about 5 to 7 bits of information, and 50% of that is incorrect. Patients remember it and it's incorrect. So most healthcare visits result in information overload and incorrect information. Next slide. So we talked about health literacy, so I won't redefine that. I'll just move on to some practical applications. Next slide. Some practical applications about how to use it. As the people have said, it's easy to understand, it's short, quick messages, it creates a shame-free environment, and it's simple to use with some practice. Next, please. The way you use plain language is to use 1 or 2 syllable words whenever possible. Give that information in very small chunks. Use visual aids whenever you can, and I've given you a link here to some very good pictograms. If you have to use a medical term, because sometimes we do, make sure you explain it, and your key messages should be limited to 3 or 5, and as Dr. O'Leary said, eliminate the nice to know messages. Next slide. Another thing that's really good to do is tell your patient a story. Let me tell you a story about somebody with a health problem like yours. Make it relevant to what's going on with that patient. Make sure you don't violate another patient's privacy, of course. Don't just use it for entertainment, but use it to teach a health concept or provide an explanation. Next slide. And if you want to know what's going on with your patient, ask your patient to tell you a story. Give me an example of the problems you have when whatever occurs. Help the patient stay focused on it. You were telling me about your headache, now you're talking about your feet. How are they connected? And after they tell you the story, say to them, let me tell you what I heard. And when you're doing this, when you're listening and repeating it back to them, listen to what's missing. So that'll give you an idea of what's going on with your patient, what their concerns may be, what they may not know. Next slide, please. So that leads into teach back, because in that previous example of listening to the patient's story and repeating it back to them, you were using teach back to assure that you understood the patient. And teach back is very, very effective. It's a nice way to open up a dialogue with the patient, and it's a nice way to increase their patient satisfaction and help them trust you. Next slide. But don't use teachback when you're talking to the patient and using teachback. Don't make the patient feel as though it's a test for them, because teachback is not a test for the patient. Teachback is a test for you to make sure that you've explained it clearly. So I like to say to a patient, I want to make sure I did a good job explaining everything today. Can you tell me how you're going to take your blood pressure medication? So that way it's on me to be make myself clear, not the patient. Next slide. I like to teach my patients to ask these 3 questions. What is my main problem? What do I need to do about the problem? And why is it important for me to do that? And I will teach them to ask me that question, and I teach them to ask that question when I refer them to a specialist for care. And sometimes I even give them a card with these questions on them so that they know what to ask and how to get the information. And if you stick to these 3 points, you'll probably be giving your patient a good start on the information they need to take care of themselves. Next slide. So having low health literacy is like being in a country where you can't speak English. And one of the things I want to emphasize here is use an interpreter if you have one. Speak slowly, not more loudly. Repeat, repeat, repeat if you have to, and avoid acronyms, idioms, and metaphors, because they don't translate culturally to someone who speaks another language. And finally, next slide. When you talk to a patient and end your visit, say something like, I bet you have a lot of questions. Can you tell me 1 or 2 you've been thinking about? And don't ask questions like, do you understand? Does that make sense? Do you have any questions? Because they end up with 1-word responses from the patient that don't give you any kind of reassurance that they understood you. And my last slide, please. So some tips. Remember KISS. Keep it short and simple. Pictures speak louder than words. Tell a story, listen to a story, and use teach back. And that's simply see it, hear it, do it, and repeat it. If your patients need other information and you don't have a handout, make sure you refer them to .gov or .edu or .org, because those are the most reliable health literacy places where the information will be reliable and valid. Next slide. So just to sum up, giving you the wisdom of Pooh, It's more fun to walk with someone who doesn't use long, difficult words, but rather short, easy words like "what about lunch?" So thank you all very much, and I'm really honored to be here today and have shared this with you.
Thank you, Dr. Reyes, and thank you, Dr. Fitzpatrick and Dr. Mayberry. I do have a couple of questions. The first question is for Dr. Mayberry. Could you talk a bit about the relationship between behavioral change, self-efficacy, confidence, and health literacy?
Yeah. So self-efficacy is one of the most important predictors of behavior. Um, Health behaviors, including medication adherence, diet, physical activity, but also health behaviors like seeking out healthcare appointments. It's this idea that I can be successful in the things that I take on to affect my health. And so that is really an important thing. And health literacy, sort of left on its own, lower health literacy is associated with lower self-efficacy. But this gets back to that idea of capacity versus ability to. If we can put supports in place, we can bridge the relationship between lower health literacy and self-efficacy so that people are efficacious. It's not that I could just be efficacious on my own with the healthcare system, but with the help of my church's patient navigator, I know that I can handle this. And so there's supports in place that increase my efficacy. And therefore, we've sort of broken the connection between lower health literacy and worse outcomes or worse health behaviors by increasing that self-efficacy to be able to control, to do something effective about health.
Great, thank you. And now I'm going to ask a question for all three of our panelists. So each one of you gave us very good ideas on things that we can do on an individual basis. But if we were trying to tackle this problem of health literacy in Nashville, I'm wondering if you could share some insight on strategically what would be our first one or two steps as a community to begin to wrap our head around this. I'll start with Dr. Fitzpatrick for this question. What can we do as a community strategically to be able to move the needle on health literacy?
I think partnerships are really important. So I think you probably have many consortia now with multidisciplinary committees, and I would recommend starting there and establishing your presence in the community as a body or a group that is committed to bridging the gap between the healthcare system and community. Through the lens of trusted, simplistic health information.
Great, thank you. And Dr. Reyes?
I think that I would start with actually engaging the providers and everybody in the organization. First, engage them, get their buy-in, make sure that they want to do this and that they're committed to do this, and getting a consensus that this is something that we want to do as a group and that it's meaningful and important and that it will be productive and will provide better care for our patients. So after I get the buy-in, that would be my first step. And then I develop some policy for the organization around health literacy so that we have a guideline, a kind of template of how we're going to do this.
I like that. Thank you. And with that policy development means sustainability. I appreciate that.
Right.
And then lastly, Dr. Mayberry, your response to the question, what can we do strategically in Nashville to begin to move the needle on health literacy?
I think taking the idea of health a little bit away from things that happen in interactions with the healthcare system. Most chronic conditions, the work of a most people have chronic conditions. The work of chronic conditions happens at home, in the family, and in the community. And so to begin to put money behind and programs that serve that gap. What is happening between healthcare visits is, I think, where we should focus our efforts to begin to reach people and move the needle.
Thank you. And that speaks to my population health background. And that's something that we haven't talked a lot about today, sort of merging that conversation with public health and healthcare. But I think our audience, that's a good take home message. So thank you. So that is the time that we have for our panel. I do appreciate each one of you joining us today and the audience questions. Just to wrap up, some of the take home messages that resonated with me: using patient navigators, making sure that we send relevant information, plain language, which feeds right back into the teach back method, and the stories that Dr. Fitzpatrick shared with understanding and trying to get to the root cause of overuse with emergency rooms and so forth, and the need for support. Thank you all for your time that we spent with us today. And I'm going to turn it over to Scott Massey from the Global Action Platform.
Thank you so much. Thank you, Vernon, for hosting today's forum. It's a pleasure to join you. Scott Massey, Chairman and CEO of the Global Action Platform. We're an international university business alliance advancing solutions in food, health, and prosperity based here in Nashville. And I wanted to share with you an example of a regional large-scale initiative that's underway to try to apply many of the lessons and ideas discussed in today's forum. This initiative is called Healthier 757, and we serve as the nonprofit partner for the initiative. Our role is to create a community-wide collective impact agenda that brings clinical, community-based organizations, faith community, various social groups and clubs, all of whom have services and programs that touch upon health literacy. Help them form a shared agenda with shared metrics so that they can collaborate more effectively and have greater impact in their community. This is all being powered and energized by a new health literacy technology platform created by a company based in Hampton Roads, EdLogix. This is a company that has created a highly incentivized gamification of health platform. It's very easy to use, connected to community services, and actually built upon population health studies conducted at Vanderbilt here in Nashville. We've been working on this now with the leadership in the community organizations and businesses in the Hampton Roads region for about 2 years. Our goal is not only to help organize the organizations in the community to improve health literacy and services related to that, but also to provide this gamification health platform free of charge to all 1.2 million citizens who live in the area. The platform has simple games that help you build and demonstrate mastery of basic healthcare knowledge issues. If you have a chronic condition, it gives you a number of games, activities that you can use to come to gain greater mastery over the knowledge of your condition. If it's just general health, you learn and gain points and gain incentives as a result of demonstrating improved knowledge and improved health literacy. So this is a way to drive health literacy engagement across a large population of 1.2 million people, bring in the community organizations to help support and reinforce that with the aim of improving ultimately the health literacy and the health outcomes for this entire region in the Hampton Roads, Virginia area. Our goal after launching the project in Hampton Roads is to bring this initiative to Nashville, to Middle Tennessee, and to implement the same kind of work, working collaboratively with local organizations, General Hospital and others, bringing the same health literacy gamification platform to all the citizens of the community at no charge, and therefore helping to drive greater engagement, greater knowledge, and much higher levels of health literacy and improved health behaviors. And I believe we're looking at a forum to follow this in which we'll be able to demonstrate platform, talk more about the actual strategy and structure. But today I was delighted to have an opportunity to give you a little appetizer taste of the initiative. Not sure who is to follow.
So, Dr. Massey, thank you. I know Dr. Martin was trying to get on. Dr. Martin, are you on with us? I can't tell. Okay, not hearing him. Amarian, can we go to you next, please, sir? And maybe Dr. Martin will be able to jump on.
Good morning. I am Reverend Marion Lee, the Director of the Congregational Health and Education Network, CHIN at Nashville General Hospital. Our mission is to mitigate the health disparities that impact the social determinants of health within the faith-based community, primarily focusing on the education attainment and access to health care. Our purpose is to position Nashville General Hospital as the primary provider for quality of health care services for the historically underserved communities. We currently have 70 plus faith total of members in their respective worship centers of 15,000 persons. We sent them our survey, and here are the outcomes. Question, Dr. Martin isn't here just in case. The questions were, how often do you have someone to help you read hospital materials? And we have roughly 36% of the congregants of our members' organizations to have someone to say that they need to help with someone helping them to read the hospital materials. Understanding written information. Roughly 40% of the congregants of our member organizations have trouble with some of the time or a little of the time with learning about their medical conditions because of the way the information is written. And finally, we asked them, how confident are you in filling out medical forms by yourself? And again, roughly 40% of our congregants of the member organizations have had trouble filling out medical forms. We were those outcomes. We looked at the glass half full with that over 60% of the persons that took the survey were doing with literacy health. Yet we want to make sure that we looking to mitigate those factors have already been lifted, and that is to collaborate with health literacy experts to contrive materials that are uniform and trusted for dissemination to all of our member organizations. Also to provide access to content of confidence within the faith community. Next, working with each congregation's health ministry to teach the health liaison about the results of surveys. We'll hold train the trainer sessions on these three factors that are generating the 40% outliers to decrease the percentage this time next year. So I'd like to say thank you all for listening to our outcomes. And I know that next is upcoming the breakout room, but I will turn it back to
Okay. Amarian, you were breaking up, so I'm going to basically, I think we lost Dr. Martin behind a firewall. And so he was going to talk about, they had done an early study with oncology patients within Nashville General Hospital on literacy. And it was interesting. I did hear one anecdote that I'll share with the group is that obviously, when we see patients today, we're masked. Everybody, we're not doing it like this, we're doing it like this. And what he finally realized what I heard the story was he realized that the patient had hearing trouble, not because he was behind a mask, but because the patient actually had hearing challenges. So as we're thinking about literacy, I think it's that spectrum of that so many of the speakers have identified that, there's where we have presumptions that we can be heard may not be the case. So I'll pass it on, and then we'll get that information to the group at a later point. So I wanted to also note to that point, if you've noticed, the session is being recorded. It will be available for review for a full month after today, so that you can go back in or you can share with others who want to find out more information about what we're doing. So to this point, what we're going to do now is we're going to go into the breakout session. So you're going to click out of the green box, which is where you are now. You're going to go into the purple box, which is live. And I will open with some direction there about what we're going to do next. And we will stay in the purple box for the rest of the session this morning. So we'll start with the plenary session. And so with this, if you'll click out of the green box and click into the purple box, I will see you there. Thank you.